What is step 4? Aha. Choose your ADHD tools with care. Many treatment options are available, but that doesn't mean everything is equal. It does mean matching the right patient with the right treatment is an unusually important responsibility of the modern day clinician who's trying to help a patient with adult ADHD. You see this clock? Anything unusual about it, colleagues? Yeah. Typically, at least here in US, the clocks are 12 hours. This one is 24 hours. Why is it here? So this is a paper I wrote, many years ago. 5 years ago. That's in our field, many years ago. And I wrote the paper on adult ADHD because I wanted to remind myself and my colleagues that there are very many unmet needs in the world of adult ADHD. And I put it around this 24 clock. May I show it to you? Check it out. You see these 5 things? Yep, different parts of the day. If we're not careful, the common needs are, even with ADHD, sleep is often a problem. If we don't choose our weapons carefully, our tools carefully, we may have a negative impact on sleep. With some interventions, our onset of action may be too slow. That may be a problem. Potency, is it powerful enough? Is it okay just to touch the symptoms, or do I need that at least 65% improvement before I really change human life? What about rebound symptoms? Do I need to find interventions that have minimum to 0 rebound symptoms? And what about afternoon hours, evening hours, late evening hours? ADHD doesn't go to sleep before bedtime. It doesn't. So this 24-hour clock that I'm demonstrating to you is a visual way to think of the patient that we're sitting across from, to really query, what are these patients' unmet needs? What can I do about it? And let me show you one other 24 clock. This is from the same paper that I and my colleagues published about 5 years ago. In case you want to read it, I think it's available easily on Medline, but if not, you just write to me. I'll send you this paper. So there we go. We need, it's very busy, isn't it? Excuse me. It's a very busy slide, but it's busy for a reason. Patients with adult ADHD have very many needs, and I have to. Not because I'm such a wonderful psychiatrist. It's just that I will not get what I'm looking for unless I think about all of these. Are they sleeping well? Are they waking up? Are they getting onset of action pretty quickly? Are they taking care of their kids well? Do they have enough attention span in the morning to help them? Are they organized at work? How is their driving, by the way? How's their work? Or if they're working at home, how is their work raising kids or running a family or whatever the case may be? How present and attentive are they in the evenings? How well are the rebound symptoms controlled, or are there none of them? How's their financial life? Are they going to bed on time? This 24-hour clock just cannot be ignored. It just can't be. So you might sit back and say, oh, this sounds very demanding. It isn't, is it? This is a very interesting disorder. It's not a disorder that goes to bed, but it's also a disorder that manifests itself differently in different parts of the day, depending on the cognitive needs life is putting on them. So as you look at the previous 24-hour clock and this 24-hour clock, I think it becomes very clear. We're not just looking for treatments. We're looking for treatments that are optimized and effective and powerful for the patient. So very many treatments. I'm not going to talk about any one of them specifically, but this is the US landscape. I don't quite know what it is in your country. It's most likely different. You probably have more options in some places than I do, maybe less options. But that doesn't matter. What matters is, do we know them? Do we know the strengths and weaknesses of each of these options? And can I actually employ them in the service of the patient. It's not that difficult a task once I remember those 4 things that I have to do. Remember those 4 things I have to do? You're right, I have to reduce symptoms. That's the first task. I don't do that, nothing else works. Every journey starts with the correct first step. So symptom reduction is incredibly important. Now let's back up a bit. Why do we even treat these disorders? Is it just to shut up the patient? Or is it beyond? Is it beyond that? If I treat these disorders well, can I potentially, if I treat ADHD well, can I potentially actually prevent bad things from happening? Like what kind of bad things? Well, certainly car accidents, marital problems, relationship problems, all that. But I want you to notice something profoundly interesting. I'm certain you are familiar with the concept of numbers needed to treat. Anything less than 10 is considered clinically significant. I'm happy to report to you with some pride in us, not pride in myself, pride in our field. We have now demonstrated as a field that treating ADHD effectively, in this case with stimulants, actually you can prevent something like oppositional defiant disorder from developing, conduct disorder, anxiety disorder, even major depressive disorder, cigarette smoking, alcohol misuse. I think I was right early on when I suggested to you that so much of what afflicts us human beings as what we call comorbidities often are the result of untreated, undiagnosed and untreated ADHD. I don't think always. I think genetically some people just are prone to 2 or 3 disorders. But isn't it nice to know that if I treat patients well, in this case with stimulants, I might be able to make a pretty significant positive impact in their life in a way that I hadn't even predicted maybe 30 years ago. So yes, we have 2 classes. We have methylphenidate among the stimulants, that is. And then we have the amphetamine class. They both are effective. I don't think there's a fight between one or the other. There shouldn't be. 41% of patients actually respond to both equally well. This is in crossover studies. 16% of patients preferentially respond to methylphenidate over amphetamines. 16%. 28% of patients preferentially respond to amphetamines over methylphenidate. So there are differences. There are some differences. It's good for you and I to know both classes of medications and to be comfortable using both. And the goal, of course, is fit the patient with the right medication. And if one doesn't work, doesn't matter which one didn't work, you can see the odds are actually pretty good that switching the class may actually be beneficial for the patient. Okay, I will continuously keep hammering on this point, and I hope you'll forgive me for it. But I never want to just treat a disorder. I want something in return. What am I looking for when I'm treating adult ADHD? And I'm very, very pleased to report to you the last 10 years have been the golden era, the renaissance of adult ADHD research. And we're finding that optimum treatment of ADHD, just remember what optimum means though. Let's be careful. Optimum doesn't mean a prescription. Optimum means psychoeducation, non-pharmacologic, pharmacologic, at least 65% reduction in symptoms, improvement in impairment, improvement in quality of life. That's what optimum means. If we do that, suicide rates go down, depression goes down, substance misuse goes down, road traffic accidents go down. This has now been shown repeatedly to be true across the world, including Nordic countries. We're going to look at some data from your part of the world. Criminal behavior goes down. What goes up in terms of negativity? Nothing. Even from a cardiac perspective, we have found no challenges with chronic use of stimulants in adult patients. So the story appears to be unidirectional. Treating ADHD well in our adult patients is just a winning strategy for the patient's family, the patient's society, the patient's environment. It just seems to be a, well, a monotonously positive story.